So what exactly is an NMO attack? How is it different from a multiple sclerosis attack? My name is Boster. I'm an MS neurologist in Columbus, Ohio. And in this video, that is exactly what we're going to be discussing. Attacks from neuromyelitis optica and multiple sclerosis and how they're different. Don't turn away because all of that starts right now. Howdy! Thanks for learning about MS with me, Boster. In this video, we're going to be talking about attacks, flares, exacerbation, relapses. It's all the same thing. It's when you lose a neurological function and a couple days go by and you got to come clean. This can be seen in the setting of multiple sclerosis, as we've talked many times in the past on this channel. And it can also happen in the setting of a cousin of MS, neuromyelitis optica spectrum disorder, or NMOSD. Now, in fact, there are some very important differences between the presentations of NMO attacks and MS attacks. And there are some really important differences in the way that they're treated. So in this video, I wanted to piece them apart and talk about those differences. Get out a pen and paper and let's jump in. So how do you define an attack? Well, the nerdy neurology definition of an MS attack is new neurological dysfunction which sticks around for longer than a day in the absence of a fever preceded by 30 days of stability with exam findings. So that's a mouthful. Both people with MS and people with NMO can have optic neuritis, and both people with multiple sclerosis and NMO can have transverse myelitis, inflammation of the optic nerves and spinal cord respectively. And they can both occur in a subacute onset. But there are some really big differences to discuss. The first difference that I would like to discuss is attack severity, like how intense is it? Multiple sclerosis attacks are quite variable. A human with MS can have an attack that's kind of not that big of a to-do, rather mild in intensity, and then the next attack can be a very severe one. This is actually different than an NMO because NMO attacks are almost always very severe. We don't have mild optic neuritis or mild transverse myelitis in the setting of NMO. Unfortunately, the attacks oftentimes result in profound blindness or massive loss of function, something that we may or may not see in the setting of MS attacks. Second, I'd like to discuss recovery from attacks. Early on in the disease course, shortly after someone is recently diagnosed with multiple sclerosis, attacks during that period of time tend to make a very nice recovery. Sometimes even without intervention, someone early in their MS disease course can have a full recovery without doing anything. This is very different than what we see in NMO. NMO attacks are quite severe and left alone almost never ever recover. That's a big difference. Real quick before we go on, do me a favor, and if you find this video to be somewhat helpful, give it a thumbs up. Also, if you haven't yet subscribed to the channel, please consider doing so. Thank you. Number 3, I would like to talk about response to steroids. Now, in both MS and in NMO, when someone has an attack, and after we prove they don't have an infection, it's a best practice to initiate steroids. And we're not giving small doses, we're actually giving really big doses. So we'll oftentimes start someone off by receiving IV solumedrol, which is given through the vein, at 1,000 milligrams a day. Now, there are some differences in the response to attacks when you give someone with MS steroids as compared to NMO. When someone with MS has an attack, particularly early on in the disease course, they oftentimes have a rather robust benefit when we get steroids. So someone's recently diagnosed, they suffer an MS attack, we give them steroids, and man, they make a robust improvement. This is not always the case with NMO. In fact, sometimes people with NMO barely respond to steroids, and this is a really big difference. When someone with MS is being treated, it's very common that we'll let them complete the entire 3 or 5 days of steroids. We may wait a couple weeks to reassess how they're doing before we decide whether further intervention is necessary. This is approached very differently, however, with NMO. When someone with NMO has an attack and we start them on steroids, if they don't demonstrate some type of improvement within the first couple days, we move on to the next step. We cannot waste time. So let's talk about that next step. That second step is called total plasma exchange. Plex, sometimes we say for short. And Plex is not a medication, it's a procedure. Now, both in the setting of MS and NMO, if the human doesn't respond to steroids, they stand a pretty good chance of responding when we start Plex. And the take home here is we need to move much, much quicker to transition to Plex in the setting of NMO as compared to in the setting of MS. In MS, we'll give someone, say, 3 or 5 days of steroids, and a common practice is to follow up with them a month later to look at their degree of recovery. And if they've made a good recovery, we're going to keep on keeping on. And if not, then we may consider more steroids or something like a Plex if necessary. NMO is quite different. If we start steroids on an NMO patient with an attack, and 1 to 2 days later, we're not seeing any response, we immediately transition to Plex. The point here is we have to initiate Plex much, much sooner if we're going to try to help the person with the NMO attack. So let me spend a few minutes and explain to you guys what exactly Plex is. So I mentioned it's a procedure. There's a giant machine, and we hook the machine up to you through large IVs that typically go in your neck. And we pull the blood out of your body through the machine, which filters the blood and then puts it back into you. Now, the filtration process is really cleaning out autoantibodies. And so we're pulling out the aquaporin 4 autoantibodies that are currently attacking the NMO patient, or we're pulling out the autoantibodies in the MS patient. And the way Plex is done is you do an exchange, and then you need to wait a full day before you do the next exchange. So we only do plasma exchanges every other day. And we typically do them for 5 to 7 exchanges. And we almost always do them in the hospital because of the seriousness of the procedure, which means someone may need to be admitted for between 10 and 14 days in the hospital to have Plex done. So it's not a small, casual thing to do. And yet, starting Plex quickly is paramount to success in the setting of NMO SD. Now, a pro tip, if I may share one with you, is that when we admit someone for Plex, whether that be MS or NMO, and we give them a Plex on Monday, I like to give steroids on Tuesday. We do Plex on Wednesday, I give steroids on Thursday. So I will alternate every other day steroids with every other day Plex. And I think that's really a best practice to get the very most recovery for that human being. Now, if someone with MS or NMO is taking a disease-modifying therapy, and then they go on and they have an attack, well, that disease-modifying therapy didn't do its job. I mean, think about it. If you're on birth control and you get pregnant, it didn't work because the goal of birth control is to prevent an unplanned event, an unplanned pregnancy. Well, the reason you're taking a disease-modifying therapy is to prevent an NMO attack or to prevent an MS attack. So, if we have to treat an attack with steroids and or pheresis, it's then important that we go back and we reanalyze the success of that particular DMT, and we may need to escalate the human being to a medicine that works better. My name is Aaron Boster, and as always, thank you for learning about MS with me, and in this case, NMO SD. And until my next video or live stream, be safe and take care.